Good afternoon and welcome to the CHEST Boston Scientific webinar. I am so excited to be here with this incredible faculty to talk about what you need to know regarding pulmonary embolus for the next decade. This field is rapidly changing, and for the first time, at least that I can think of, we've got significant randomized clinical data that will help guide decision making. My name's Dr. Michael Jaff. I'm a vascular medicine specialist and chief medical officer for the vascular division of Boston Scientific. I'm joined by an incredible faculty that's here to talk you through their perspectives on where we are and where we're going to go. Let me take a moment to introduce them. Paul Currier is a pulmonary and critical care physician at Mass General Brigham in Boston. Peter Monteleone, an interventional cardiologist from Ascension Health in Austin, Texas. Soophia Naydenov, a pulmonary critical care physician in Washington University in St. Louis. Patrick Troy, pulmonary critical care medicine at Hartford Healthcare in Connecticut. And let's begin this program with Dr. Currier. If we can go to the next couple of slides. Paul, I'm going to introduce you to talk about why and when to consider device intervention for pulmonary embolus.
All right, let's get started then. Thanks so much for having me. Let's go to the next slide here. And I wanted to frame this whole conversation just starting with a case. And this is a patient who had been in my ICU about 3 weeks ago, was my patient. And he was 76, had a history of IPF, and had had a single left lung transplant several months before we met him. He'd also had a left upper extremity DVT after his transplant. He was on anticoagulation. And he had a planned interruption in his anticoagulation for a transbronchial biopsy, just for surveillance for his transplanted lung. And he'd also recently taken a log car trip. And so I think we can all kind of see where this is going. He presented one day before we met him with acute dyspnea on insertion. And when he was in the ED, his vital signs looked pretty good. Pulse of 81, blood pressure 141/87, SATs at 97% on room air. That we did desaturate to the mid 80s getting out of bed. All right, next slide, please. And this is a representative cut of his CT scan. You can see here the pulmonary embolism there on the left and the pulmonary artery. And then we'll just go to the next slide too. We have a nice coronal view here. There you see again, the clot there in the left pulmonary artery going distal PA. And we just go to the next slide. And so the question is, how would you treat this patient? I can tell you that on CT and on echo, there was no evidence of right heart strain. The NT-BNP was normal. Interestingly, there wasn't a troponin that was done. So what do you think? And let me tell you what happened. We started low molecular weight heparin. And after discussion among the PERT team, ECOS catheter-directed lysis was performed. So maybe a bit of a surprising intervention to some people, maybe not. We'll talk more about that at the end of my part of this presentation. And so let's keep going though, because time is short. So I wanted to further frame this discussion with a brief history of venothromboembolic treatment. And I had a chance to do a book chapter on PE a few years ago and look at some of the history. And I think it's just so interesting to see where we've started and where we've come, maybe how far we've come, maybe how far we have to go, actually. But really, the first and what I think will be the only treatment trial for treatment versus no treatment for pulmonary embolism was published in 1960 in the Lancet. And I don't know if anybody has seen this, but I just wanted to read on the right here just for a second because it's fascinating in terms of how the pulmonary emboli were diagnosed. And so it says the clinical features on which the diagnosis was based reflected the presence of acute right-sided heart failure or of pulmonary infarction or both. Right-sided heart failure usually declared itself with faintness, central chest pain, a fall in blood pressure, and a rise in jugular venous pressure, together with changes in the electrocardiogram. When pulmonary infarction occurred, the common findings were pleuritic pain, hemoptysis fever, pleural fiction, loss of resonance of the lung base, and rouse. In these patients, it was usual to find changes in the bedside chest radiograph, tenderness or swelling of the calf or other signs of thrombophlebitis strengthened the diagnosis, but some of the patients had no abnormal signs in the legs. Fascinating, right? And so this was essentially a diagnosis based on physical exam along with a little chest X-ray and EKG. My, how things have changed. All right. So next slide, please. So, and the treatment here. So this is incredible again too. So they were given the treatment group got heparin, 10,000 units every 6 hours for 6 doses, along with nucumolone, essentially a sister of Coumadin, and then the outcomes. And this is what's really incredible. So the untreated cases, 5 out of 19 of the patients died, and in the treated cases, zero of the patients out of 54 died. And so this is again why I think it will be the only such trial of anticoagulation versus no treatment for pulmonary emboli, diagnosed as they did back in 1960. Next slide, please. So a lot of these sort of treatments that we're using are really actually have been around for a while. So anticoagulation since the 60s, first case of lytic therapy, streptokinase being used for pulmonary embolism, published in 1964, and even advanced therapies like catheter-based treatments. The first transvenous pulmonary embolectomy by a catheter device done by Dr. Greenfield that was published in 1971. So these have been around for a while, and since that time, we've been working on trying to figure out which patients are going to benefit from which treatments. And this is the main theme, I think, of this part of the talk is that we still have a long ways to go and we need better data. Next slide, please. And so, what do we do in medicine when we don't have all the data we would like, which is kind of always, but particularly in this field, we develop consensus based guidelines. And I would argue that it is just really indicative of pulmonary embolism treatment in terms of how far we have to go based on the fact that we have both consensus guidelines in the literature for generally how we treat. And then we also have an acute consensus team, aka PERT teams, to do this. It's like a Delta Delphi sort of situation where, again, it was like layers of consensus. And why do we have this? Because we have the need for expert opinion because we don't have all the data we would like. Next slide, please. So, alluding to that, there's so much variability actually, or at least I'll say a reasonable amount of variability. And so, like even the society guidelines for risk stratification. I have this slide up here just to show how much variability exists between the different societies that give recommendations on treatment of pulmonary embolism. Next slide, please. I think for most of us, though, I think the classification that's published in the European Heart Journal is probably the one that we find most useful. And so, as you, I'm sure, know, early mortality risk is the main thing that this is focused on. And that's an important point, too, because we don't have the data that we would like for longer term outcomes. And so, looking at early mortality risk, dividing these groups into high or groups that have hemodynamic instability, arbitrarily, I would argue, defined as a systolic pressure less than 90 or a drop of greater than 40, and then have right ventricular dysfunction on their echocardiogram or CT. And then the low group, jumping down to that, the group that doesn't have our defined hemodynamic instability, has no high risk factors. And then perhaps the group that's maybe most difficult in terms of trying to figure out how do we best treat these patients, the intermediate, divided into high based on whether or not there's presence of RB dysfunction and elevated troponins, or low based on not having those present or one of those being present. And notably here, NT-BNP, right, measured in our patient, wasn't even actually included in the stratification system at that time just because of lack of clinical trial data based on that. So moving to the next slide, please. And so it's useful, I think, probably that this classification system, I think, is pretty useful because it really does correlate with outcome, at least from a short term or even 90-day basis. And you'll see here, this is kind of like this graph because it shows really as you move from that low risk stratification here in the green and move down this, you're essentially falling off a cliff, right? Down to, unfortunately, to death here, and goes up mortality as you go from intermediate to high risk as well. Next slide, please. And then how do we treat these patients? There's variability as well in the society guidelines. Again, just underscoring the need for better understanding of what treatment is really effective. Go to the next slide. I think, again, just taking the low early mortality risk patients, really there's a general agreement that anticoagulation is the right treatment. Next slide, please. And then in the high risk group, there's a reasonable amount of agreement with not great data, I will say, that Thrombolysis and the consideration of advanced therapies is really probably the way to go. Go to the next slide again, too, please. And this is just from the CHEST guidelines, one of the many guidelines for treatment. And it says in these high risk patients and patients with hypotension who do not have a high bleeding risk, suggests systemically administered thrombolytic therapy over no such therapy. Again, this is a weak recommendation with low certainty of evidence. And in those patients who do have a high bleeding risk or failed thrombolysis or shock, this is interesting, right? This is in the consensus guidelines, likely to cause death before systemic thrombolysis can take effect. How long is that, right? Then they recommend catheter-based therapies, and again, too, with a weak recommendation, low certainty of evidence. And so this is again the need for more evidence. Go to the next slide, please. So again, general sort of building of consensus around these recommendations with weak confidence and weak data. Next slide. And then in this group, then the intermediate high and intermediate low group, what do we do for those patients? And we know, from the original Pythos study, at least for what was called intermediate at that time, intermediate high patients, though, really, is that lytic therapy is effective for pulmonary emboli, but unfortunately also causes significant bleeding, particularly significant head bleeding to 0.2% of cases there. But in reality, in clinical practice, I think it's much higher. And so, I think we've all been at the bedside and you're trying to make this decision on whether or not to give lytic therapy, and it's difficult. And that is always in the back of my mind. And so, what do we do? Next slide, please. And I think just thinking about these two and thinking about how can we intervene at a point where we're going to avoid the patients really falling off that cliff and spiraling into this death spiral, and looking at these patients and thinking about just from the pathophysiologic standpoint that as the RV starts dilating and we see this NT-BNP starting to increase, and knowing that there's stretch to the right ventricle, and seeing the troponin increase, and knowing that there's some ischemia in that right ventricle, and the contractility is starting to decrease, and that our preload is then going to decrease, our cardiac output is going to decrease, the lactate's going up, and trying to intervene before we get to this point of no return when the systemic blood pressure starts dropping and the death spiral has really started. Next slide, please. I'll just present some provocative studies. And again, so this is, it's not great data, but this is looking at large databases actually. And this one, so 42,000 patients actually, intermediate high risk group, looking at the outcome with catheter-based therapy, and showed a lower risk of 90-day mortality with catheter-based therapies and compared to other treatments. This is confounded like crazy. Most importantly by patient selection. So we can't actually use this data, I think, as anything to hang our hat on. But again, same thing in the high risk patients, confounded without a doubt, but this idea that perhaps catheter-based interventions can be effective. Next slide, please. I'll just go quickly through this and just say, just for the sake of time, that interestingly, this was actually just a study that came out of the Annals of Thoracic Surgery, showing that an in-hospital mortality of 20% in these surgically treated patients for pulmonary embolism, because this is also something that needs to be on the table, was 20%, which is actually construed to be a good mortality actually for these patients, given their high risk of death. Thrombolysis, 16% in hospital mortality, catheter-directed intervention, 7%. Again, this is going to be hugely confounded by patient selection. Next slide, please. So when do I consider, though, device intervention? As somebody who is not the person who is doing this procedure, I like to consider it fairly broadly. And I think about it in all hemodynamically unstable patients where lysis is contraindicated, certainly, it's failed, feels like lysis may take too long. This is part of the guidelines, but really in any of these patients, I think, because I personally, when I'm at the bedside, make the decision to give lytic therapy, it's a scary thing to do. And I like the idea of having more control. Of course, it's important that there's the ability to provide these advanced therapies. I think also thinking about it in the hemodynamically stable patients who have worsening hemodynamic or respiratory status is important. And then these patients who we expect will not do well with ongoing clot in their pulmonary vessels. And so this is our patient who actually would have fallen into the intermediate low risk category. But the reason that patient actually underwent that intervention was because it had this one good transplanted lung that now had clot in it, didn't have bronchial circulation. And really we were unsure whether or not the patient would be able to tolerate having that clot in there and what would their long-term outcome look like with the knowledge that we don't have a good understanding of those outcomes even with catheter-based interventions. So the intermediate high risk patients are to be considered, and then patients just with large amounts of clot in the vessels. But we need better data on this, and I think that's where the rest of our conversations today are going to lead us. So I'll turn it back to Dr. Jaff.
Thank you, Dr. Currier. That was a great background. I remember that paper and forgot how dramatic it was to read. So thanks for highlighting that. Next, we're going to turn to Dr. Naydenov, who's going to give us a pulmonologist perspective on the gaps and evolving expectations in care for pulmonary embolus patients.
Thank you so much. I really enjoyed the talk, Paul. Loved the historic perspective, and the case was absolutely amazing. So, thank you everybody for joining this such an important topic and conversation and spending your afternoon with us. So, as you can see, my topic, I'm excited to talk about this. Next slide, please. So, the first thing I want to say broadly is that the pulmonary embolism that we see today is different than the pulmonary embolism a decade ago. It is just not the same PE, and it is not so much about the clot or its location, but it's about what is happening around the care for pulmonary embolism patient. If we step back a little bit, this conversation around PE changed. It changed when the Ultima trial was published around a decade ago. And this intermediate risk category of PE, where we struggle as to what to do, this trial, which studied a catheter-directed thrombolysis versus anticoagulation, gave us this reference of RV-LV ratio improvement with catheter-directed thrombolysis faster than heparin could do. It's just a matter of time. Heparin catches up ultimately 30 days later. But this was a signal that perhaps something can be done with something in addition to anticoagulation for this patient population. Next click, please. The PITHO trial around the same time was published and really provided us with a lot of information that is helping us and is kind of a base that is set for this intermediate category of patients. Paul has mentioned this trial. It was very, very helpful to know that there was a benefit when the patients who got tenecteplase, this was a study with tenecteplase versus anticoagulation only in intermediate risk PE patients, and there was a clear signal of benefit with tenecteplase. It's just, as Paul highlighted, it's this the consequence of what it came with that is not acceptable. So we don't do systemic thrombolysis in intermediate risk patients for this after what we learned from this trial. But clearly the signal itself cannot be ignored. But can we do that safely is the big question. Around the same time, the PERT consortium, the all volunteers getting together, scratching our heads and figuring out what to do for what patient. And we've made a lot of progress. I want to just acknowledge that at this time. Next slide, please. So the then and the now of PE has transformed. Not changed, I'd say transformed. The moment we are in, it really, the field has evolved significantly and at a pretty rapid pace. So it was an all size fits, all anticoagulation was all we would do and hope for the best. That's the then. But where we stand today, it's a risk adaptive model. Not perfect, but that's what we got right now. There's a structured team-based management, whether it's a PERT or some kind of a structure that exists in your institution, is the way we look at PE today. Device data, as I mentioned, there's a signal towards some benefit. And of course, we can't wait for the RCTs that are coming to guide us further as to what needs to be done and what is that benefit and how does it play out in long term. And we care about these long-term outcomes. It is important, we want in that acute setting the patient to survive. Of course, there's no question about that. But we also care about what we do in this acute setting. How does that translate long term? Is their functionality restored or not? And what can we do about it in the acute setting to make sure that that happens, the patient has the best chance to restore their functional capabilities? AI integration is becoming a norm. Next slide, please. But with all that said, what are the gaps and the blind spots? Because we struggle. What isn't working in the systems today? So risk stratification. we know about the troponin elevation and the RV, dysfunction or dilatation, but still it is sometimes not done in the patients that we see them or not done timely. So that's a gap still that exists. There's a delayed or inconsistent reaching out to your PERT if you have one, or to the next person that can perhaps do something more, whether it's an intervention of any sort, but just that conversation, there's still a delay. People wait for that deterioration that, we don't have a good parameter, whether you have new score implementation or some other ways that you decide when are you going to act. And the post-PE care, very, very important to clinicians and, of course, to the patients, is kind of an afterthought. We don't have a structured follow-ups in many places still. And as I mentioned, the communication across the entire spectrum of PE care amongst the subspecialties, I think that's very, very important. Next slide, please. Some of the other gaps, blind spots, however you want to call it. PE is a dynamic process. The decision that you made at 8 a.m. may not be valid at 2 p.m. So what is the structure in place at your institution? It's just more of a reflection inwards to see where we all stand wherever we practice. How do we pick up on that deterioration? Again, going back to the Pytho trial, 5% of patients in this risk category in which the mortality is not as low as less than 1%, like we have in a low-risk PE patients, which thankfully is the majority of the patients. But this intermediate risk mortality is anywhere between maybe 5-15%, which is significant. So how do we practice? How do we attend to that patient a little bit later if things have changed? And what parameters or guidelines do you have for your institution to pick up on those and prevent those from happening? Or even if they've happened, to timely intervene. All very significant. So this dynamic disease process is something which I still consider as a blind spot for clinicians. Interventions, this language of too aggressive, I think that needs to change. If we haven't learned anything from the recently published, not recently, I think it's like a year ago now, Peerless trial, the catheter-directed thrombolysis and mechanical thrombectomy, looks like both can be done in an expert hand safely and timely, and it's well tolerated. And this device-to-device debate, I think, in my mind, is kind of not needed. I always think that these are tools, they work differently. And sometimes you need a hammer, sometimes you need a wrench or a screwdriver. So each of them, it depends on the task at hand, what you need and what you're going to implement. So I think there's a more learning as to which patient needs which therapy, or perhaps something hybrid is needed. So the too aggressive language for this interventional approach, I think, is kind of a thing of a past. And convincing data exists that in expert hands, they can be deployed and patient can be intervened upon pretty safely. And there are disparities in access. Hispanic patients, Black patients, they're not treated the same. And many of even the endovascular options are not given to them the same. So we need to be aware about our practice. And I think these things matter as far as PE care disease spectrum is concerned. Next slide, please. So where are we going? How are these expectations evolving? What shall we do? Because I feel like everybody has to join in. This is more of a reaching out a hand and saying, okay, join this. I think the standing on the sideline is not going to work anymore, because we are all going to head in this direction together. And it's good to join in these conversations like you are today. And I think these are evolving expectations from clinicians, whether you're a cardiologist or pulmonologist or hospitalist playing a role in this spectrum somewhere. AI-assisted triage, I think, is going to be implemented sooner or later. There's no way around it, in my opinion. I think it should be used. These are valuable tools, and we need to learn and maybe help with these training of the models further as clinicians, and we know what things matter and how we make our decisions. RCTs, they will reshape the guidelines, and I think that's very important. I can't wait to see what implementations we will have in the near future. And we need to be ready to implement those. We need to be aware of the disparities in access, and whatever we can do in our capacity. I think I want to highlight that point. It is important because all patients, in my opinion, if they should be offered the therapies in despite of whatever their race or gender or age is. Longitudinal ownership is important, P. Like I said before, acute care, yes, of course, very important, but what we do in acute setting, how does it pan out in long term in patients' health or return of function is also very important. So the next generation of P care will be data-driven, multidisciplinary, and patient-centered. Next slide, please. So where do my colleagues, my pulmonologists fit in this? And if it's a cardiologist practicing in the same spectrum, I don't want to be fixated to say this only applies to pulmonologists, but I'm talking about this opportunity, I'd say, where we sit in this, intersection of acute triage and then the risk stratification piece, long-term recovery, and really this population health piece is also very, very important. So there's a shift of this just reactive consultation, writing, maybe a note and then disassociating yourself with that patient. I think this leadership and this multidisciplinary response is very important, and I think it's an evolving role. Increasing involvement, like I mentioned, risk stratification, then figuring out in your institution who to reach out to and reaching out early. Because if you pick up on this intermediate risk PE patients, I'm not talking about high risk because I think those are just clinically easy to identify, but I'm talking about those where it's a little bit of a gray area. And that's where it is more a need for coming together, having that conversation. Is this the patient that should be on my radar? Or perhaps intervene now, or maybe you can say, okay, if there's a change in news score or something like that, then perhaps we should consider intervention and discuss amongst your team members what would that intervention perhaps be for that particular patient. So I think all those conversations and having them early in the course of patient's disease is important because, like I said before, it's a dynamic process. And I think this is a new responsibility to have this involvement in follow-up clinics and learn this post-PE functional impairment. With many, 30-50% of patients are left with post-PE functional impairment. So it's good to be involved in that. And I think it's clinically also very, very important. Next slide, please. So I'll leave you with the checklist. 4 things to do now. I'd say, in my opinion, be proactive. That means the risk stratification, escalation of care. I think it's good to reflect on those ahead of time before maybe you have have an intake wherever you're practicing as to what that workflow is. Because I think PE patients are statistically common, so you are already taking care of them. So have that system analysis wherever you're practicing. What's the best way? If you have a PERT, that's outstanding. But if you don't, connect to those people and help build that structured approach like PERT. So be proactive, be connected, and reach out early, I'd say. Be longitudinal. That means all PE patients deserve structural follow-up. It doesn't have to be with a specialist. It could be with a PCP, so on and so forth. But if things are not going right, there should be some guidance in place that, CTEV, CTED, and this post-PE impairment, we care about these. So have a structured follow-up to identify and take care of those patients. And I think be ready for change because device therapy is here. And I think RCTs will define its role in the near future. Next slide, please. To my closing remarks would be, I've already highlighted some of the, the blind spots or gaps, you can say. There's a tip of the iceberg. You can see that, but there's a lot underlying, whether it's disparities in care or some of the other things I've highlighted. So, I think we're really standing at a threshold of a new era in PE. We have moved forward to that practice decades ago, diagnose, anticoagulate, and hope for the best. I think we've moved forward. We have moved forward to a more proactive, more collaborative, and more precise care. And the guidelines will guide us further. But the big question is, are you ready? Thank you.
That was fantastic. Thank you so much. There was a lot of great advice there that I'm sure those listening will take to heart. Dr. Monteleone, now it's your job to portray the dizzying armamentarium of device-based therapies available.
Wonderful. Thank you all for the chance to be here. Thank you for the wonderful talks, conversations, and to Jess for helping us put this together. Let's dive in. Dizzying array is the right description, Dr. Jaff. So let's talk about the PE therapies that exist and the ones that are emerging and all these different opportunities to treat these patients that you've decided have needed advanced therapy. So the way we're going to break this down, we're going to talk a little bit about mechanical thrombectomy. We're going to talk in general We're going to talk in particular about some of the most frequently used devices, and then we're going to talk about ultrasound-directed catheter thrombolysis. Let's go to the next slide. So in general, when we think about mechanical thrombectomy, we're thinking about removing clot using suction or using different types of mechanical devices. There are some pros to this. There's an immediate effect. You're taking clot out. You're not administering any thrombolytic. We're going to talk a little bit about thrombus in transit. So clot that's not reached its end destination might be free floating in the right ventricle. All major pros to mechanical thrombectomy. On the con side, these are large sheaths. A 26 French sheath is thicker than my thumb, and you're putting it in a patient who you're anticoagulating as their focused therapy for their venous thromboembolism. These could be long cases. We're going to dive into that a little bit. Your access site options for mechanical thrombectomy are limited. If you've ever put a 26 French sheath in through someone's neck, and I have, that's not the most pleasant experience for the operator, for the patient. So you're usually working femoral in patients that sometimes can't lie down flat because they're so dysmic. There's vessel injury risks that might be at the leg, or that might be more catastrophically in the lung. You're using stiff wires to deliver these large devices when you're trying to deliver a 26 French sheath up there. Um, you don't always just aspirate the thrombus out. That thrombus sometimes gets quote unquote lollipopped, stuck in the distal edge of the catheter as you're trying to suck it out, and then you try to drag it back through the heart. 1 in 4 of us have patent foramen ovale, and so the opportunity for that lollipopped clot to partially break off and escape and cause a microvascular left-sided embolism causing a stroke is a real phenomenon. You see it clinically. In general, there's a bleeding risk. And then there's questions about distal tissue perfusion. You pull out the proximal cork. Is that really happening helping the distal lung bed? Next slide. There's a lot of these, as was alluded to. So, this is just a list. We're certainly not going to talk about every one of these devices. You could try to, but many of these, might not necessarily see the light of day. Many of them might not see contracts making them available at your local site or facility. There's some different mechanisms of attempted action. There's a lot of movement towards exponential growth and expanse of this field. Next slide. In general, in practice, we're going to talk about these 3 devices that make up the mass majority of use, certainly in our hospitals, likely in your hospitals, and definitely nationally. So we're going to break it down through talking about the mechanisms of action of the penumbra devices, the Inari devices, and the angiodynamics alpha vector. Next slide. So penumbra is kind of representative of engine-powered aspiration. So penumbra with the newer versions and quote unquote that lightning flash 2.0, it's a 16 French device as opposed to 26 French. There is a driven engine. So it's not aspiration coming from the suction of the syringe. There's actually a powerful engine driving aspiration. You'll hear the term CAVT, or computer-assisted vacuum thrombectomy. Effectively, there's algorithms that are driving when aspiration is happening versus non-aspiration in attempts to fatigue clot and assist getting clot out through a smaller sheath. Penumbra is very responsible in testing and assessing the attempts at blood return. You can't return blood that's been aspirated through engine. It effectively just gets annihilated. The joke is you're returning maybe red fluid if you try, but it's certainly not blood because the power of that aspiration obliterates blood. And so if you go to the next slide, so the goals of these systems has been to decrease the amount of blood you're taking out. There's certain visual cues, whether it's flashing lights or sounds between the different generations of the device, that try to alert the user to when they're just pulling frank streaming blood out and trying to slow that process down to optimize clot retrieval while minimizing the attempts at blood return. Next slide. The Inari flow retriever device, purchased in recent months by Stryker. This device is simpler mechanistically. Effectively, it's a well-engineered, flexible 26 French tube. So you put that purple tube up into the lung over a very stiff wire, and then you aspirate with that large syringe. There's adjunctive nitinol discs. You can see those discs on the slide there. And what those adjunctive discs are attempting to do is they're attempting to deal with wall-adherent clot. So if you can't get anything out, if you're trying and lollipopping clot and you can't remove it, you try to deploy those discs and drag back what might be left. Next slide. The benefits to a large 26 French sheath is that aspiration flow rate is oftentimes driven by lumen size. So the bigger the tube, the easier it is to suck clot out. It kind of makes simple sense, both in terms of what can fit through the tube, but then also what you have the ability to actually capture. Now, the thing about a 26 French tube is you pull a lot of blood. And so there have been attempts to develop blood return systems. You'll see the flow saver blood return visualized in this video playing in the bottom right-hand corner. Effectively, you draw out a bunch of blood, you push it through a filter, you try to take some of that blood back through the clot and then return the blood. There's some safety data about using that system. There's really no safety data about what happens when you're pulling blood around clot through a long tube, then putting it through and then putting it back in terms of what you're actually returning. There's a lot to be learned about what we're doing in that field and in that system. But the goal is to help decrease blood loss that you can get pulling blood through a large tube. Next slide. And then there's the angiovac or alphavac system. So AngioDynamics had the angiovac, which was around really before a lot of these other devices. So best explained, angiovac was effectively VV ECMO. One of the cannulas has that funneled end tip, that soft funnel to attempt to engulf and engage clot. And with the angiovac system, you required a perfusionist. You'd be pulling blood in through one cannula. It would go through a filter, but not an oxygenator, and then be returned. It gives you the ability to deal with a lot of mass being removed. Still, we'll use it for IVC reconstructions and those types of cases. However, the complexities of having a lot of blood outside of the body, being pushed through a perfusionist system are certainly complicated. It can slow down cases in sick patients and require perfusionists within your system to be able to run these devices. Next slide. AngioDynamics took the same funneled catheter and put it on a more of a straightforward aspiration system, and that's the AlphaVac system. So the AlphaVac cannula has this waste bag you're pulling back, like you're kind of pulling on that handle to aspirate, and then clots going into waste. Next slide. Couple different shapes of catheters. You'll see these used in different settings, whether it's for trying to deal with tricuspid valve endocarditis or thrombus inside the right ventricle, or actually dealing with PE, being used and explored in various ways in clinical trial data. Next slide. This is an important slide. If you have a fully functioning PERT team, there's an absolute role for mechanical thrombectomy. So next slide. So this case, for instance, this was a young Marine in Austin, Texas. He came in with a big PE, and as the line goes, we hadn't seen the end of the movie yet. So he also had free-floating thrombus, a cast of his iliac vein inside the right ventricle. You can't get that out. You can't deal with that with anticoagulants alone or with thrombolytic. It'll break up and it'll embolize. So you go get it. So next slide. This was a case. He also had some IVC thrombus. We took this out with the angiovac device, and you can see that large cast of the iliac vein that was removed. It actually occluded and corked the catheter. It looks like a good picture. In reality, that whole system was clotted off, and we couldn't unclog it, so we had to take it out. We lost a lot of blood, but we got out that large thrombus in transit. Next slide. Here's another case. This person had tricuspid valve endocarditis. The team tried to angiovac it, the CT surgical team. Go to the next slide. They thought things had gone great. 48 hours later, he was floridly hypoxic. They did a CAT scan, and this was new. There was a new occlusive right-sided pulmonary embolism. Go to the next slide. We went up and got it with a FlowTriever, and that's what we took out. So that's not clot. When you send that for pathology, if you go to the next slide, that's staph. So that's a combination of staph and fibrin thrombus admixed. They got some of it off the valve, thought they got all of it. In reality, a lot of it embolized. And you're not going to be able to lyse that. You got to be able to take that out. Go on to the next slide. This happened 3 weeks ago now in Austin, Texas. So with someone in our labs was doing a gel foam pelvic vein embolization. They attempted to release the gel foam, and the patient started coughing. They realized the gel foam wasn't where it should be, and they went looking for it. To their credit, they found that little marker. First, they thought it was in the heart. You come into LAO, you can see it's in the lung. And so we went up and got it. You can see what we removed, that chunk of gel foam with its marker, by putting a 16 French thrombectomy device through a 26 French thrombectomy device. It's not a low-risk procedure, shoving a tube all the way out in the lung, but we managed to get that piece out. You certainly couldn't lyse it. It's metal and foam. So next slide. This is another key slide. Just because you sometimes need mechanical thrombectomy, that does not make mechanical thrombectomy the workhorse therapy for pulmonary embolism. I'm not quite sure how mechanical thrombectomy became the workhorse for pulmonary embolism in a lot of labs. And we'll talk about some of the considerations there, but this is an important caveat. You might need all of them for a multifunctional complete PERT system, but in terms of when you're choosing your standard device, there's some considerations there that might push you in a next direction. So next slide. So the case for ultrasound-assisted catheter-directed thrombolysis, or ECOS, is a workhorse. We're going to go through effectiveness, efficiency, and safety. Next slide. So the ECOS catheter, which we've talked about a little bit already, you can see what it looks like on X-ray. So there's a catheter in the right and a catheter in the left pulmonary artery. As you see in that blue image in the middle, it's a dripped infusion catheter. And then in addition to the ports for drug, there's an ultrasound core that goes in through the catheter. And the ultrasound energy effectively is provided to loosen fibrin and give you the chance to actually infuse at lower doses thrombolytic into that clot, break up that clot with lower doses of thrombolytic and do it more effectively. Go on to the next slide. As has been alluded to, this is the best studied device in venous thromboembolism. So back in 2014, we had the Ultima trial, which actually gave us randomized data for the first time against conservative therapies, showing that these therapies work in terms of clinical benefit. Not until a couple weeks ago did we start seeing some of randomized data, coming out of the mechanical thrombectomy arms with other devices. We have single arm prospective data with Seattle 2. We have dose optimizing data in Optilice. We have knockout data for large registry data for safety. HiPython we'll be talking about later today in terms of landmark clinical trial data. Go on to the next slide. The science of this is really interesting, and we talk so much about pictures of clot on the back of the table. I've been surprised that this field does not talk more about the actual alveoli. Tissue perfusion is one of the most important things when we think about blood flow salvage, and it just hasn't been as much of a discussion in PE, which is quite strange. Greg Piazza presented at ACC just a couple months ago this Optilize 3D data, where they really looked at this kind of for the first time. So using a high resolution 3D CTA, they looked at what was happening to small and medium sized venous volume, with the thought being it's not just the clot that you pull out of the proximal vessel. What matters is the ability to improve flow going through the capillary. And so they looked solely at the ECOS patients that were treated in the Optilize trial, and they said, sure enough, we can see that small and medium-sized venous outflow coming from the alveolus is improving when treated with ECOS catheter-directed thrombolysis. That's a really big deal as we start thinking about who's getting better and why. Next slide. This matches up with the Seattle 3D data done by the same laboratory, where they're actually looking at tissue perfusion, and they showed that the only right ventricles that got better were the ones whose distal tissue perfusion got better. It's not about the size or the diameter of the clot on the back table. It's about how you're impacting distal tissue perfusion. And ECOS and ultrasound catheter-directed thrombolysis, it's the only technology that we've really seen and demonstrated that this is improving, driving the benefit that we're seeing clinically. Next slide. Now, these are both my cases, in patients where we, for various clinical reasons, decided to treat mechanical thrombectomy or treat a clinical trial. And the concept is you're sometimes going to get these great pictures of clot on the back of the table, and it's hard to look past that. But go on to the next slide. These are also my cases, and we joke sometimes, though it's horrible, that there is a percentage of cases where when you're trying to aspirate clot out, you're left with small amounts of stuff being removed, and you're hunting for like the smallest syringe in your cath lab to take a picture next to you to feel like you did something. This is a not insignificant portion of these cases. These are also the highest risk for negative outcome cases. Go on to the next slide. And so interestingly, we're starting to see some outcomes data. So this was just presented in JSky a couple weeks ago. This was actually looking at mortality as well as looking at CTEPH between blue, large bore mechanical thrombectomy cases, and orange CDT, catheter-directed thrombolysis cases. This is the Trinetics data, and it's propensity matched. And interestingly, the curves when we're looking at outcomes for CTEPH, the incidence of increased frequency of CTEPH comparatively with mechanical thrombectomy versus CDT, it becomes more striking at 1 year than in 6 months. This signal might speak to what we're seeing about what happens with distal tissue bed perfusion. Taking out the proximal cork with mechanical thrombectomy might not rescue you from the risk of CTEPH in propensity matched cohorts to the same way as dealing with distal tissue bed perfusion does with CDT. So go on to the next slide. So, in addition to this, in addition to the effectiveness, there's also the importance of efficiency and the importance of safety. Next slide. The Peerless trial was alluded to. This was an Inari-sponsored trial looking at large bore mechanical thrombectomy by expert Inari operators versus any kind of CDT. Looking just at the time of the cases. So folks in the trial who are doing this all the time, these are an hour and a half long cases for mechanical thrombectomy. That's about as good as it can get. The CDT arm of 65 minutes is a little bit interesting. So if we go to the next slide, this is the last frame of a live recorded case we did at Viva back 4 years ago, and in that setting we did a bilateral ECOS case. You can see the X-ray on the left side. Took a skinned close for 16 minutes and 30 seconds. And so ECOS can be very quick cases. Go on to the next slide. So why does efficiency matter? Yeah, it's great for me. I can get more in my day. It's great for the cath lab, especially if you have an understaffed lab like so many of us do nationally, especially because these are added on urgent non-scheduled cases. Most important part, and I'm not telling pulmonologists and critical care doctors anything they don't know, this is extremely important for the patient. If you have a patient with a failing right ventricle, less time lying down in a cath lab and lower sedation doses is huge to prevent catastrophic hemodynamic collapse. Not bolusing someone with heparin up to an ACT of 300 for a long procedure is a big deal. And most importantly, less time out of the controlled environment of the ICU with shorter cases is huge. Next slide. And so finally, safety. So next slide. The knockout registry, if we go to the knockout registry showed us in a large group of 489 patients that the risks associated with ECOS and real world utilization and registry data, risk of bleed, risk of major issues was all very, very low. Go on to the next slide. Nonetheless, there's this long held consideration that went along with high dose systemic TPA, that bleeding is a huge risk associated with the TPA. Now, that's true for 100 milligrams of IV push systemic acute TPA. And so it made it into the literature being discussed as CDT, low risk, low dose TPA being contraindicated because of bleed risk. Next slide. Peerless came out and Peerless didn't show this. So if you look at Peerless all-cause mortality, sponsored by Inari, there is no difference between the groups. And next slide, and major bleeding, no difference whatsoever between the groups with Inari operators that are as good as they get, right? This is in the clinical trial. Go on to the next slide. Now we did this real PE analysis. So this looked at real world data with the Truveta data resource. Imagine looking at 17% of the care across all 50 states with real-time data availability. Go to the next slide. So we looked at what real docs are doing to real patients. And when we compared ECOS versus FlowTriever, we saw, not surprisingly, that all risks of bleeding were lower, both ISTH and BARC3B, when in the real world, patients are treated with ECOS versus treated with Inari. Not that striking, of a finding, not surprising when you think about you're putting a 26 French tube in someone that you're bolusing with heparin, there's going to be a real deal bleed risk. There's also a higher 30-day readmission risk in these propensity matched patients treated with back to you. Go to the next slide. We saw in real P as well that the risks of intracerebral hemorrhage were low, both for ECOS as well as for Inari FlowTriever. We got yelled at a bunch because we actually showed that the risk of bleed in the brain was a little bit higher with mechanical thrombectomy as opposed to with ECOS therapies. Go to the next slide. Everyone kind of stopped yelling at us when Peerless came out because it showed the same thing. So there's no difference in intracerebral hemorrhage in Peerless between CDT of any kind or Inari, again, with expert Inari operators. There was 2 intracranial hemorrhage events with mechanical thrombectomy and 1 with CDT. Really matches up what we showed from. Real quick on the win ratio. So the win ratio statistic was positive in Peerless. The only thing that drove it was the fact that, this clinical deterioration marker, not mortality, not bleed, not intracranial hemorrhage, this wasn't really a clarified outcome. And the concept was trial operators effectively decided trial therapy was working. And these are 2 very different therapies. That's a very difficult statement to make. Next slide. So, in short, as you're thinking about safety, we don't talk enough about the concerns. And I say this is someone that does these procedures of pushing a 26 French tube through the heart. So go to the next slide. This was a case of someone who we were treating, clot was lollipopping, clot was not coming out. We were doing our best to try to remove it. Go to the next slide. We thought we were done because we couldn't do anything anymore. And all of a sudden the patient couldn't move her left arm or left leg. Go to the next slide. This was a catastrophic embolism across a PFO with M1 MCA occlusion. And so a large thrombus removed. Go to the next slide. You can see where that was missing on cerebral angiography. Next slide. They did their best to get it out, but the patient did not do well. Yeah, this was another case where they took this picture with a mechanical thrombectomy FlowTriever device. The patient then had a seizure. The question came up of what happened. If you look closely, you'll realize that this is actually a FlowTriever pushed across a PFO and an angiogram into the left atrium and a large air embolus to the brain. Go to the next slide. This is another case. You can't see anything here. This is a testimony to the fact that digital subtraction is hard. This was a patient who was actively splitting blood out during the case. We had a distal perforation with a 26 French tube. We were trying to coil it. That's almost impossible to do. We needed selective embolization, reversing protamine. Go to the next slide. Really kind of a catastrophic bleed in that situation. This was a case where we were trying to embolize kind of large burden of thrombectomy, a relatively new PE operator. Go to the next slide. Continuous attempts to do this, not realizing that a large tube was occluding the outflow tract of a severely impaired right ventricle. Patient became hypotensive and pulseless during the case and PA arrested. Go to the next slide. And, this is just the last image of that heart not moving as they were getting ready for ECMO cannulation. And that's the CPR. Go to the next slide. So conclusions, we've got a lot to learn about this huge armamentarium. There's a huge role for thrombectomy, but there's a clear advantage for these simple, straightforward workhorse therapies like ECOS. There's a lot of risks associated with all of these situations. You've got to be prepared for critical complications. but we have to expand use of some of these proven therapies, but do it in a thoughtful way. Thank you guys also.
Thanks very much, Dr. Monteleone. And to wrap this up, we've asked Patrick Troy to talk about the randomized trials that will transform PE care. Pat.
Thanks, Michael. And Peter, thank you for using the word alveoli, rarely heard by an interventional cardiologist. Much appreciated. Next slide. Let's get started. So the question becomes, why, if we have all this great technology, all these great things, why are we only intervening in 4% of cases? Why? And the answer is we don't know what to do. We're pulmonologists and we're conservative by our nature. We like RCTs and we don't have a lot. Next slide. So my goal here is in 9 minutes or less to basically talk about a clinical framework for how we are going to evaluate some of these trials that are coming down the pike. And now they're coming fast and furious. And 2026 is going to be a banner year in the PE space. And I think the critical questions are as follows. Can we proactively identify the optimal patient population to intervene on? And the real big question is not which device we should use, but are any of these things actually better than anticoagulation by itself? And when we're looking at outcomes, are they clinically meaningful? And I reference back to Pytho. Is there mortality, cardiovascular collapse benefit? Is it better than intervention than anticoagulation alone? And is the endpoint clean? And Peter alluded to this, not hidden in a win ratio, which can kind of masquerade what the true endpoints are. Is the clinical benefit something that we can see in a relevant period of time, meaning before hospital discharge or 7 days? And above all else, as physicians, as providers, is this something, whatever we're doing, that has an acceptable risk profile? Next slide. So what do we know? Where are we these days? Well, good news, there's 4 big RCTs coming, right? And so I'm going to defer high Pytho for a second and go from sort of right to left. So PE tract, I'm going to just briefly touch on, is an NIH-based trial looking at sort of a mishmash of intermediate low, mostly risk pulmonary embolism patients. They're measuring functional outcomes, important in its own right. I'm going to give it its due diligence. It's valid, it's important. It's not necessarily answering the fundamental question that I think we really want to know in the short term, which is, hey, if I have an intervention, whatever it is it better than anticoagulation alone when it comes down to mortality, cardiovascular collapse in a meaningful period of time? This trial, PE tract, is not going to answer that question. So what about the other 3? Storm PE just reported out at TCT. I'm going to come back to that one in a second. Let me focus for a second on Peerless 2. This is a trial that's enrolling right now. It uses mechanical thrombectomy, the Inari device. Big trial certainly by our pulmonary standards, about 1,200 patients, about 100 centers. And it's looking at intermediate high-risk PE. It's sort of a juiced population, if you will. This is sort of a new trend that also the high Pytho trial has. We're looking at least 2 risk factors from each of these 3 categories in the middle, including hemodynamics, like sort of blood pressure between 90 and 100 or an elevated heart rate, biomarkers, elevated troponin, BNP, and kudos to the use of lactate. If I could just put a plug in briefly, utilization of lactate is a really helpful discerning marker for your patients, particularly young ones, when they're sitting there looking okay in the ER, eating a ham sandwich, or thinking everything's fine, yet there they are sitting with a lactate of 6. A reason to really be concerned, as we heard earlier, about impending cardiovascular collapse. The problem that I have with this trial, so the good things, all right, you're going to compare device to anticoagulation. I like that. You're going to do this in multiple patients, multiple centers. Great. It's the endpoint that I have a problem with. It's a win ratio. I won't spend a lot of time talking about it, but we're not getting a clean endpoint on cardiovascular collapse and or mortality like we're going to see in the high Pytho trial. So it's going to be more difficult. It's not for nothing. It's a good trial, but it's going to be limited because of its outcomes in terms of how we are able to discern how useful they are. Next slide, please. So let me basically touch on Storm PE, which just reported out. Now, this is the Penumbra Lightning System. This is a trial that is answering a question, intervention versus anticoagulation alone, as Peter was sort of alluding to some of the earlier data. The problem here is that their outcome, right? Well, and I'm going to come to that in a second, but before we get there, patient population looks like they're pretty sick. They all have elevated cardio biomarkers. They use the NEWS2 score, which is sort of an emerging development in the PE space that we'll see with high Pytho. The problem is, I'll touch on in a second, is this NEWS score that they had averaged around 4. As it goes in NEWS, which I'll talk about in a second, that's a pretty quote unquote non-sick population. So this is unlike the population that I think we're going to see in High-Pythos and the Peerless 2 trial. Next slide, please. My concern, and I thought what was interesting, just as an aside in this trial, is the utilization of low molecular weight heparin. This trial enrolled between 2023 and 25, only 15 to 19% of patients on low molecular weight heparin. That's pretty stunning, actually, since, I mean, if I can put in another plug, if you leave with nothing else, low molecular weight heparin is the way to go. And if you look to the right on this slide, the reason is clear. There is no excuse to have less than 100% of your patients at therapeutic anticoagulation within 48 hours of admission. It really, and this is a trial they're running, and yet even in this trial, they can't fully anticoagulate all the patients. An aside, but an important point, look, got to use low molecular weight heparin for sure. Next slide, please. What were they looking at? Well, they're not looking at the endpoint that I care about. They're looking at a proxy marker, RV-LV ratio, which we believe correlates with recurrent PE, mortality, et cetera. But this is data that's already been out there in the space for mechanical thrombectomy and for ECOS at least, for the better part of a decade. So this isn't getting to the fundamental question that we care about. Next slide. So there's some long-term data here as well in terms of 6-minute walk tests. I'm not sure that I draw much meaning from 472 versus a bit higher in terms of 6-minute walk tests, but certainly interesting to consider. Next slide, please. So basically, Storm PE not answering the questions that I think we really need to know about at the end of the day. And it's actually sort of just putting itself on par with what's already known about mechanical thrombectomy and ECOS technology. Concerning about the anticoagulation data, certainly. And this population, just and when you think about sick, not sick, it's in the not sick category, certainly from a news category perspective. More data needed when it comes to this device. Next slide, please. So news, basically, we use it in the PE space, in the critical care space. You all know, hopefully, what it means. The higher the number, the worse. 7 is bad, continuous monitoring. Next slide, please. So what about the High-Pythos trial? So the High-Pythos trial basically is looking at ECOS plus anticoagulation versus anticoagulation alone. And it's looking at 7 days, so meaningful time point, at the composite clean score of PE-related mortality or cardiovascular collapse or PE recurrence, right? It's using that similar kind of enriched population, which I would call PE plus, right? So they have troponins, they have evidence of RV strain, but they also have to have something else, meaning tachycardia, relative hypotension, or a respiratory rate greater than 20, or OT-sat less than 90%. And they're going to standardize in this the use of the ECOS device to infuse over 7 hours and a total dose, depending on catheters, 9 versus 18 milligrams. 1 catheter 9, 2 catheters 18, with no arbitrary crossover. It's all going to be based on the new score. So really objectifying what crossover is. Next slide, please. So again, PE-related mortality, cardiorespiratory decompensation or collapse, and PE recurrence, all of this independent blinded outcome for adjudication. And cardiorespiratory collapse is sort of defined as cardiac arrest, need for CPR, new signs of shock. Here's a new one: use of ECMO, use of intubation or mechanical, non-invasive mechanical ventilation, or a new score, as we were talking about, greater than 9. Super sick population. Next slide, please. We're also going to, again, look at these elevated markers, including tachycardia, relative hypotension, elevated respiratory rate. Next slide, please. And the flow is pretty clear, right? So their patients will be assigned to a therapy, randomized, consented, begun on therapy within 2 hours of randomization, and will have good outcome at both 48 hours, 7 days, 30 days, and longer-term data at 6 and 12 months. Next slide, please. So essentially, it's the first large randomized trial, I'm referring to High-Pythos, which is going to establish what we do with this patient population, because it has the power to show the impact of ECOS therapy on the prognosis of intermediate high risk, right? And therefore, potentially, the potential to change and alter guidelines. Next slide, please. We're also going to get a variety of long-term data that includes all-cause mortality, bleeding risk, hemorrhagic stroke, long-term development of some of the CTEP, health economic assessments, all things that we've sort of talked about a little bit earlier. Next slide. And I'll finish with the idea that, look, brighter days are coming ahead. We're going to be able to, in 2026, proactively identify and target this intermediate high-risk patient population who's going to benefit the most from intervention beyond anticoagulation alone. No more with the games of which device is better than that device, which device is better than anticoagulation alone. And we'll define these benefits in clinically meaningful terms, and I'm talking death and cardiovascular collapse, and we're going to do it in a meaningful time period, before discharge or 7 days. We're also going to clearly delineate the risks of these interventions, meaning bleeding. And I think with this totality of data coming, we're going to be able to provide evidence which is going to impact guidelines, and we're going to look at therapy differently in the year 2026. With that, I will stop.
Thank you, Dr. Troy. Let me thank the entire faculty. There's a QR code for those of you who are still on. If you would just use your phone, use your camera, answer a couple of survey questions so that we can make these programs even better. We look forward to talking to you in the future as more data comes out about this incredibly exciting field of pulmonary embolus. Thanks again to the faculty and to CHEST.